Good evening to all our followers on social media and a warm welcome to yet another webinar brought to you by Emerson Laboratories in association with Times of India. May 5th of 2023 was commemorated as World Pulmonary Hypertension Day. So what exactly is pulmonary hypertension? Here to help us understand more about this frequently misdiagnosed disease and to also help us understand how to cope with patients living with this disease, we have an expert panel of specialists. It gives me great pleasure to introduce you to them. Dr. J.L. Shah, DM, FSCAI, FESC cardiologist, Ahmedabad. Doctor, welcome.
Yeah.
Dr. Vyom Mori, interventional cardiologist, Narayana Hospital, Ahmedabad. Dr. Akash Ramchandani, associate consultant cardiologist, Sterling Hospital, Ahmedabad. Dr.
Hi.
Gopal Rawal, consultant pulmonologist, critical care and sleep disorder specialist, Shilp Chest Diseases Center and Sterling Hospital, Ahmedabad. Dr. Neil Thakkar, consultant pulmonary and critical care physician, Sterling Hospital, Baroda and Pulse Clinic, Vadodara. And Dr. Milan R. Bhanderi, pulmonologist at Wokhart Hospital and Medicare Hospital, Rajkot. Doctors, a very warm welcome to all of you. And at the very outset, a grateful thank you to you from all the followers and from all of us at the organizing end, because you've taken very precious time out of your schedules to be here with us. Let's begin our webinar with my first question to Dr. J.L. Shah. Doctor, please can you help us understand what exactly is pulmonary hypertension and how is it different from regular hypertension?
Good evening and thank you so much for inviting me. And this is a very important topic and a very misdiagnosed entity, which is pulmonary arterial hypertension. So, in layman term, we can explain that there are two types of hypertension: systemic hypertension and pulmonary arterial hypertension. Pulmonary arterial hypertension is a very rare and a progressive lung disease where your arteries which connect your hearts and lung becomes narrowed, blocked, or damaged. So ultimately, it makes very difficult for the blood to flow normally through the lungs, and thereby increasing the pressures of that arteries. And by definition, when the pressure of that artery is more than 25 millimeter of mercury at rest, or if more than 30 millimeter of mercury during physical activity, we called it as a pulmonary arterial hypertension.
Thank you, Doctor. And I think as we go along, we'll be able to familiarize our followers and listeners a little more with this absolutely alien subject that we're talking about right now, actually. Dr. Vyom, my question is to you now. How common exactly is pulmonary hypertension? And who is at risk?
Yeah. So, the general prevalence of pulmonary hypertension is around 1% of the total population. But when we talk about idiopathic pulmonary hypertension, where usually we don't find the cause of why the pressures of pulmonary artery have raised, that incidence is very less. It comes down to 15 people per a million population. So what the registries say that patients with prior left heart diseases and those with chronic lung disorders are more commonly one of the causes for pulmonary arterial hypertension. And when we talk about idiopathic, where usually we don't find the cause, there sometimes we find that genetic factors play a major role in causing the pulmonary hypertension. And those patients are the ones which are usually misdiagnosed because they are young, they are female, and usually they are misconception that they are having some functional symptoms. But usually it's the development of pulmonary arterial hypertension which is going on and progressing slowly.
Thank you, Doctor. Dr. Akash, let's talk about something I think almost everybody asks, is pulmonary hypertension hereditary? Is there any connect between the two?
Actually, pulmonary hypertension is there is a 6 to 10% population which has the genetic predisposition. But majority of cases doesn't have the genetic predisposition because it is a wide spectrum disease. It has the multiple reasons. One is the left heart disease. As I told that there is a right heart and left systemic hypertension, pulmonary hypertension. The left heart disease is the one of the major cause of the pulmonary hypertension also. Other than that, lungs are very common cause. The idiopathic pulmonary hypertension common. Hereditary has some role. It is 6 to 10%, not more than that. But 90% cases are not genetic. It is a non-genetic, and it is multifactorial disease. So the genetic predisposition, we cannot tell that exactly it is the hereditary, but it has some component. Not all patients. It is around 6 to 10% of population of pulmonary hypertension patients.
Thank you, doctor. And so therefore, Dr. Gopal, my next question is to you. If only 6 to 10% is hereditary, what are the factors that can cause or contribute to pulmonary hypertension?
So when we initially, it was, first of all, thanks MSN and Types of India for creating this good awareness program on pulmonary hypertension, because we all know about the hypertension, as Dr. Jair has mentioned, systemic, but this is the blood pressure of the lung, the pulmonary hypertension. So you have to keep a very high index of suspicion as a cardiologist and as a pulmonologist. So common cause is either it could be, as earlier my colleagues mentioned, that is a cardiac causes like heart failure, some congenital heart disease, valvular heart disease, which is responsible for pulmonary hypertension. But simultaneously, chronic lung disease like bronchitis, interstitial lung disease, lung fibrosis, autoimmune disease, then sleep apnea. As a sleep specialist, I have seen a lot of patients who having that pulmonary hypertension, and the underlying factor is sleep apnea. And nowadays, this is increasing the drug abuse in the youngsters. If they don't know these drugs are harmful and can leads to a pulmonary hypertension, so that things you have to come in the mind. And those at last, those who are residing at high altitude, in that kind of patient, you have to suspect the pulmonary hypertension, which increase the pressures of the lungs artery.
Thank you, doctor. Of course, I think we'll get warm up and get into more details as we go further. Dr. Neil, now that we've kind of, discussed what are the causes of pulmonary hypertension, can we get into the symptoms? And this is, I suppose there are two kinds. One is the set of symptoms that you doctors look out for and, see and to diagnose. But perhaps from a layman's point of view, what exactly should cause us to suspect pulmonary hypertension?
Thank you for the question. And again, thank you MSN and Times of India for this awareness initiative. So this is related to the previous questions, because whatever symptoms pulmonary artery hypertension will have, some of those symptoms will be related to the cause of the pulmonary artery hypertension. Some will be because what the pulmonary artery hypertension does, and third will be what complication it causes. So for a layman person, simple breathlessness or air hunger or fatigue, देखिए थोड़ा थकान लगना, सांस चढ़ना, थोड़ा थक जाना, these are all common symptoms which a patient with a pulmonary artery hypertension can have. He can also have syncope. He can also have sometimes simple dry cough, or because of the underlying etiology, as Dr. Gopal has discussed with us, that if you have sleep apnea, you will have increased दिन में ज़्यादा नींद आना, या रात को ज़्यादा खराटे होके choking हो जाना. If you have an underlying lung problem, you will have breathlessness, सांस बढ़ना, खांसी आना. If you have a cardiac problem, you will have chest pain, angina, कि चलने के बाद थोड़ा छाती में ज़्यादा दर्द होना. That is also a symptom which can be, it can mimic like a heart attack also, because there is some hypoperfusion which can be caused by the dilated pulmonary artery. Sometimes it can even cause something which is completely not related. As an example, there can be hoarseness of voice. Sometimes a dilated pulmonary artery, जो आपकी स्वर पेटी होती है, जो वोकल कॉर्ड्स होते हैं, उसकी नर्व को भी ये पल्मोनरी आर्टरी दबा सकती है, इसके कारण आवाज बदल सकता है. So these are all some of the symptoms, but it can have varied presentations based on the etiology or the how severe the pulmonary artery hypertension is.
Doctor, you used a word earlier, syncope. Did I hear it?
Yes.
What was that? Could you explain that term?
Syncope basically what means is कि कई बार अगर if you feel dizziness and lightheadedness and that causes you to transiently it is a transient unresponsiveness or you get like थोड़ी देर के लिए आपको फेंटिंग का अटैक आया तो मेडिकल भाषा में उसको सिंकोपी बोलते हैं या फिर फेंटिंग होना पर वो पल्मोनरी आर्टरी हाइपरटेंशन के कारण भी या फिर अगर वो कोई कार्डियक कॉज के कारण है तो उसके कारण भी सिंकोपी का जो चक्कर आना या फेंट हो जाना वो प्रॉब्लम हो सकता है.
Okay. So those are very important things that I think हम सब लोग को जान लेना चाहिए कि what are the symptoms that they should look out for. Thank you so much, doctor. That was very clearly described. Dr. Milan, can you now tell us since this is something that is strange, तो पता नहीं कि treatment हो पाएगा कि नहीं क्योंकि do people even understand that it needs to be treated? So can you help us understand what happens if this is left untreated?
Yes, look, this is such kind of disease that if it left untreated, almost all patients of pulmonary hypertension develop some form of complication, right? And most common out of this, most common complication is heart failure, particularly right side of heart failure, which is also known as cor pulmonale in our terms, in medical terms, right? Look, if pulmonary hypertension remains untreated, so what happens? That our right sided of heart has to pump blood in lung against high pressure system. Right? As Dr. Jayal Saha sir has explained that it's a low pressure system. Its pressure is below 25 millimeter of Hg only. But in some such patients of pulmonary hypertension may go above 50, 60, 70. In some patients, it even reach up to 100, 110. Right? So it's at such high pressure, right heart has to work very hard. So as time passed, there is dilatation in right side of ventricle because it become weakened as time passed, and also dilatation of right atrium. So it leads to pedal edema. Pedal edema means there is swelling in ankle and also swelling in anterior abdominal wall, and also associated with congestive liver means there is swelling in liver and congestive gastropathy, also known as swelling in stomach. So swelling in liver and swelling in stomach can cause severe anorexia. Patient cannot eat. Patient feels persistent nausea, vomiting, and so ultimately, we have even seen some few cases of cirrhosis of liver. If it remains untreated, it's cause congestive hepatopathy, and ultimately, as time passed, some patient may develop cirrhosis. So this is such fatal disease, right? So ultimately, it leads to poor quality of life, very high morbidity with very high mortality. So and yes, also associated with other common other complication also like cardiac arrhythmia. It's arrhythmia means it's irregularity in heartbeats. Also some patient may develop hemoptysis because there is definitely high pressure. So when there is some form of breakage in artery, it will lead to more blood loss, more hemoptysis, and may lead to clotting of blood vessels in small pulmonary arteries.
Okay, thank you, Dr. Milan. I think that entire list is cause enough for everybody to ensure that they understand the seriousness of leaving pulmonary hypertension untreated, and hence they should be consulting their doctor. Dr. Jail, we're still in this particular realm of discussion where I'd like to ask you, especially in today's time with the kind of lifestyle that people are leading, is there any special age group that seems to be increasingly becoming victims of this type of hypertension?
Yeah, definitely. Thank you for this question. And because of the emerging and very stressful lifestyle, there are certain risk factors or certain other drugs which might work during in the development of pulmonary arterial hypertension. Particularly if you are taking any anorexia and any weight reducing pills or certain antipsychotic or certain other CNS drugs, then it puts you at a very high risk for development of pulmonary arterial hypertension. majority of cases of pulmonary arterial hypertension are idiopathic, which means that there is no identifiable cause, and it can happen usually usually diagnosed after 50 to 60 years, and more common in females. So there is no such any other lifestyle predilection which leads to or increases the risk of pulmonary hypertension. But ultimately we have to focus on our lifestyle. So we have to make certain other lifestyle changes, like in our diet, in our habits, particularly in relation to addiction, because many young generation is now indulging in like smoking and other fancy addictions. So that might lead to pulmonary damage, lung damage, and might increase your chance of developing pulmonary arterial hypertension in the future. So always we have to strive for a healthy lifestyle, and maintaining healthy body weight and other such parameters might help you in avoiding the development of the disease.
But so I'm just taking a point out of what you just said. What you are saying, and I just need you to answer me in a kind of a simple mode, because we are going to cover the rest of the topics. But you're saying that it can be avoided.
Yeah. So in some cases, like that there are certain risk factors like cigarette smoking. So these are certain other modifiable some of the factors may work while reducing the risk, reducing the pulmonary lung damage. Because already someone has mentioned cor pulmonale. So that is an advanced stage of pulmonary arterial hypertension, where your right side of the heart is excessively stressed to work against a very high pressure. So certain diseases, certain your lifestyle and certain addictions which might lead to future pulmonary damage, that can decrease the risk. But far or more or less, most of the cases of pulmonary hypertension are idiopathic, as I have mentioned. There is no any identifiable cause, and some subset of patients are also having a familial cause, like there is a family history, means the disease is running in the families. So if the person is having any positive family history, or some person in the nearby first degree relatives or family has already diagnosed with this disease, then he should undergo a regular screening for the development of for this disease.
Thank you so much, Doctor. Dr. Vyom, now that we've talked about the kind of patient profile and the, who can get it and what's the causes, let's now move to the area of figuring out how exactly is pulmonary hypertension diagnosed. So what type of tests would you recommend to diagnose this disease?
Yeah, so very important thing is an index of suspicion, because sometimes it can present with very subtle symptoms like breathlessness on exertion, fatigue, or lightheadedness. So the index of suspicion should be high whenever you feel that you are not able to find the cause of this particular symptoms. At that time, we should start thinking about this pulmonary arterial hypertension. So routinely, the first test which usually is being done is then echocardiography to rule out pulmonary arterial pressures by echocardiography. So if it's normal by echocardiography, usually we consider it that patient doesn't have pulmonary arterial hypertension. And second thing which we see is sometimes patients with gray zone, where we are not very pretty sure by echocardiography that this patient is confirmed having pulmonary artery hypertension or not. So in those situations, we would do cardiac catheterization in those patients to confirm our diagnosis. And once we have confirmed that the patient is having pulmonary artery hypertension, then we start looking for other tests to find out what can be the causes. So basic tests usually done are CT chest, CT pulmonary angiogram. We prefer to do thrombophilia profile in some patients, or test for autoimmunity by doing ANA. Rarely it can also be a manifestation of HIV. So these are some basic tests which we usually do once they are diagnosed. But definitely first screening test is echocardiography.
Okay, thank you, doctor. I think that is also something that the layman is familiar with when you see an echocardiogram. Dr. Akash, now that we have progressed and moved from testing, the obvious next part is the treatment. So, could you tell us what are the treatment options for pulmonary hypertension patients?
Pulmonary hypertension is actually a big umbrella of disease. It has a very broad spectrum of disease. It has multiple causes. So from my side, I feel, first of all, we have to diagnose what is the reason of pulmonary hypertension. If there is a cardiac cause, I can tell that prevention is better than cure. Once pulmonary hypertension develops, then it is difficult to treat it. Like if a child has the, like in layman language, we tell there is a hole in the heart. So if child develops symptoms, child is not feeding well, if he has hole in heart, the treating hole in heart as soon as possible can prevent the future development of pulmonary hypertension. Like if patient has the symptom of breathlessness and we do the echo, patient has the valvular disease, patient has the valve problem, or patient has the heart failure, left side of heart is weak, then treating the left side of heart is the important treatment to treat the pulmonary hypertension, progression of pulmonary hypertension. But what is the treatment part? I will come to treatment part. One is the drug, which is the, if the pulmonary hypertension because of the left side of heart, like hole in the heart or valvular disease, treating with medication of pulmonary hypertension will not be very useful. So there are drugs like phosphodiesterase inhibitors like sildenafil and tadalafil. Sildenafil is a short-acting drug. We give the 3 times in a day. Tadalafil is a long-acting drug. So these drugs are not good in the left side of heart. So these are the actually drug for idiopathic pulmonary hypertension or patient develop the core pulmonary. So these drugs will be helpful. Other reason, there can be a reason that it can be like pulmonary thromboembolism. Patient develop the pulmonary thromboembolism. It's a very common phenomena. In pulmonary artery, there is a clot. We diagnose it as soon as possible, we treat it as soon as possible, will prevent the future development of pulmonary hypertension. But once it is developed, then we use the medication. So as I told, one medication is the phosphodiesterase inhibitor. There is second group of medication, which is the endothelin receptor antagonist, which is the bosentan, macitentan, and ambrisentan. The ambrisentan is now, because the sildenafil and tadalafil is not used with bosentan, so we use commonly with the ambrisentan drug. Other drugs, if patient has advanced pulmonary hypertension, then the drugs, other iloprost or teraprostinol can be used, but it is not right now available. In case of pulmonary hypertension, because of clot in heart, like CTPH, chronic thromboembolic pulmonary hypertension, in that case, one drug, Rausigot, can be also used. So these are the different drugs. There are 3-4 drugs which are available. They can prevent the progression of pulmonary hypertension. They can slower the progression of pulmonary hypertension. But these all drugs cannot stop to develop the pulmonary. They cannot stop complete reversible of pulmonary hypertension. They cannot reverse the pulmonary hypertension. They only slow the progression of pulmonary hypertension. So these are all the drugs we have. First thing that we should diagnose the cause. According to that, we treat that cause, that pulmonary hypertension should not get developed. If developed, then these are the group of drugs which we can use to treat the pulmonary hypertension.
Thank you, doctor. So I'm sure that all of us who have just heard your listing will trust our doctors to be able to prescribe the appropriate medicine. Dr. Gopal, let me continue this question line of thought with you, and just to get a little bit of clarity for all the different versions of pulmonary hypertension that we're talking about. Are the treatment modalities the same, or are they different?
Yeah, as Dr. Akash has mentioned, first of all, when you diagnose pulmonary hypertension, then you have to identify the cause, whether it's a group 1, that is a idiopathic pulmonary hypertension, whether any cardiac condition which is responsible for the pulmonary hypertension, lung conditions which is responsible for the pulmonary hypertension, any clots, or some we call autoimmune disease that is more common in a female, and sometimes in HIV patients also. So we have to identify the cause, and important thing, pulmonary hypertension is not a curable condition. It is a treatable conditions. So that things, and you have to give the time to the patients, because here we need a good rehabilitation. We have to explain the patient why he develops this pulmonary hypertension. We find out the cause, And according to that, what Dr. Akash has mentioned, group of the drugs. And first, which cause is responsible? Whether the lung problems are responsible for the pulmonary hypertension, cardiac problem, and you have to explain the patient how much he will recover, because here the drugs which we are using, that is slow down the progression of the condition, and that helps to maintain the good quality of the life of the patient. That is the most important thing. And you have to explain about the supportive therapies, like if the patient having low oxygen level, then you have to give the oxygen therapy, breathing exercise. Sleep apneic patient suppose is there, then you have to give the positive that machine, by what we call is a CPAP machine. So that things you have to explain the patient. These are the available treatment, and these are the supportive treatment which not cure your condition, but which restrict the progression of the disease. That is the most important thing. And explain the patients, you have to continuous follow up with the doctors. That is most important, because your doctor may change your treatment after some time according to your condition. That is the most important thing.
So also, doctor, I'm going to stay with you and ask you one more question, which is that as per what Dr. Jayal also shared with us, a lot of women are affected, and perhaps women in the prime of their lives. So that naturally brings us to the question of pregnancies. So what is the deal with pregnancy and PH?
Yeah, so that is a very that what we call the threatable combination, pregnancy and female. Though pulmonary hypertension is common in female, so if your patient is diagnosed to have a pulmonary hypertension, then it is better explain your patient to avoid the pregnancy, and they can use a contraceptive method. That's the ideal is the barrier contraceptive method they can use, because what happens, they are in the childbearing age group. So you have to explain that better to avoid the pregnancy. That is the most important thing. And suppose patients become pregnant, then that she needs a good follow-up. Otherwise, what happens, because of the pregnancy, there is a lot of hemodynamic changes occurs, and ultimately the heart, the right side heart, which is already loaded, and this pregnancy gives more stress to the right side heart. And as Dr. Milan has mentioned, there is a chances of worsening of the failure of right side failure of is there. And you can explain, if your lady is pregnant, then the mode of the delivery should be a cesarean section, and in time, because certain drugs which are using in a to treat the pulmonary hypertension, that is somewhere have a contraindicated, that should not be given to a pregnant lady, because that drugs will affect the growth of the child also. So and you have to give that blood thinner injection also, and close monitoring. And if the patient comes to you for a delivery, then the best mode is the cesarean section. You can give the supportive therapy and close monitoring, because pregnancy and pulmonary hypertension, the chances of mortality is increased 10-15%. So that things you have to keep in your mind.
So from any which way you look at it, if even if they have PH and they decide to go ahead with the pregnancy, the medication itself is dangerous to the unborn infant.
Yeah.
So, but tell me, doctor, so therefore, isn't this a huge issue for parents and the social system and their own environment? How does it work?
So that's the most important here. The counseling and the things have come, because sometimes what happens, the child delivered, but there is a chances of mother loss is there. So everything has to be keep that the gynecologist and all that should work in a proper teamwork to, if the pulmonary hypertension lady become pregnant. So that is a close team required till the baby deliver. That's the most important.
Correct. Thank you, Dr. Gopal. Dr. Neil, since we are talking about medication and treatment, etc., and this is like a lifelong kind of a thing that you have to live with. What kind of lifestyle changes should patients be looking at?
So normally we've discussed a lot of information regarding medicine, diagnostics, and therapy. So in terms of lifestyle, first will be, if we think, will be regarding the dietary changes, that what diet a patient of pulmonary artery hypertension or a patient who has progressing pulmonary artery hypertension, what diet can help them. So there is the limitation in the salt intake overall that is going to help these patients for pulmonary artery hypertension. Secondly, there is specific dietary modifications as per the cause of the pulmonary artery hypertension. As an example, if a lung disease, a chronic lung disease is going to cause severe pulmonary artery hypertension, then over a period of time, such patients do require a good, because the disease itself is going to cause a lot of wasting and weight loss. So in such cases, they would require a good protein intake in their diet. That would require a good amount. If they're having eggs, the eggs would be needed, or paneer, tofu, or whatever good milk. Milk is the one of the best sources of protein in vegetarian diet. So again, as per the condition, if they have a cardiac condition, they would have to go down on the oily foods, cheesy food, processed foods. These need to come down. They need to be more on whole grain foods, nutritious, fresh green vegetables. Fresh food is more preferred in such cases. Second important thing with the diet is the fluid. So again, the amount of water intake that a patient of pulmonary artery hypertension will have will be different from what a normal person would be having. They have to limit the amount of fluid intake they can take. If they have severe pulmonary artery hypertension, they already have a tendency of overloading. So in layman terms, what that means is that अगर आपका लंग्स का प्रेशर काफी ज्यादा है, तो अगर आप ज्यादा पानी पीते हैं, जैसे आप 3 4 5 लीटर तक का पानी रोज पीते हैं, तो वो चीज आपके इवेंचुअली लंग्स में ऑलरेडी देर इज चांसेस है कि थोड़ा पानी भर के आपका प्रॉब्लम भी थोड़ा बढ़ सकता है. तो ऐसे केसेस में थोड़ा पानी का इंटेक या फ्लूइड इंटेक थोड़ा रिस्ट्रिक्ट करना जरूरी है, स्पेशली अगर इसमें कोई कार्डियक कारण भी इन्वॉल्व है. तो ऐसे केसेस में अगेन वी हैव टू मॉडिफाई द फ्लूइड इंटेक. इसके अलावा जो लाइफस्टाइल चेंजेस में आता है, वेरी इंपॉर्टेंट पॉइंट डॉक्टर गोपाल हैज डिस्कस्ड सम एक्सटेंट इज रिहैबिलिटेशन. कि अगर आपका जो स्पेशली विद रिलेशन टू लंग्स, कि जिसमें आपको बेसिक न्यूट्रिशन का आपने ध्यान रखा, बेसिक ब्रीदिंग एक्सरसाइजेज आती है, जो थेरेपी आपके डॉक्टर ने आपको दी है, जो बिकॉज पल्मोनरी आर्टरी हाइपरटेंशन विल रिक्वायर वेरी स्पेसिफिक थेरेपीज, देयर आर स्पेशल ड्रग्स, इट विल रिक्वायर स्पेशल केयर नीडेड. तो वो जो भी डॉक्टर ने आपको बताया उसको फॉलो करना जरूरी है. कंप्लायंस इज वेरी इंपॉर्टेंट. इसके अलावा बाहर जो भी वैक्सीनेशन, इवन बचपन में जैसे हम वैक्सीन लेते हैं, वैसे ही अडल्ट्स के लिए भी जो भी वैक्सीनेशन आती है, वो बार बार आपको कोई पल्मोनरी रिलेटेड, लंग रिलेटेड प्रॉब्लम होके वो पल्मोनरी आर्टरी प्रेशर बढ़ सकता है, तो वो वैक्सीनेशन जरूरी है. साइको सोशल सपोर्ट, कई पेशेंट्स ऐसे हैं जिनको बहुत सीवियर पल्मोनरी आर्टरी प्रेशर है, ऑक्सीजन भी घर पे लगा हुआ है, ऑक्सीजन की जरूरत पड़ती है, तो उनका मानसिक तनाव में आ जाते हैं, वो लोग डिप्रेशन में आ जाते हैं. तो ऐसे केसेस में कुछ लेवल तक साइको सोशल सपोर्ट की भी जरूरत होती है. सो ऑल दिस कम्स अंडर रिहैबिलिटेशन. सो न्यूट्रिशन, रिहैबिलिटेशन, लीविंग योर एडिक्शन. डॉक्टर जयल हैज एक्सटेंसिवली डिस्कस्ड रिगार्डिंग एडिक्शन. यानी कोई भी एडिक्शन है आपको, स्मोकिंग है, अल्कोहल है, ड्रग्स है, ये सारे हैं जो लंबे समय के साथ, यानी अगर आप आपके पल्मोनरी आर्टरी हाइपरटेंशन का ट्रीटमेंट चालू रखना है, and with that you are continuing your addiction, there is no use of therapy, or if at all use, it is very limited use, because your disease is going to progress with that addiction. So very important message here should be that you have to stop your addiction if you are going to take specific care with regarding to your pulmonary artery hypertension. तो आपका जो भी addiction आपको है उसे छोड़ना, especially smoking, alcohol and drugs, these three are going to cause a lot of problems. So and exercise again with lifestyle is that ऐसा एक myth है that if you have pulmonary artery hypertension, you sit on the bed only, you don't move about. ऐसा नहीं है. You need to have limited good exercise programs with your physiotherapist या जो आपकी मदद कर सकते हैं, कि so that you have a devised plan of daily mobility. It is important that you move about. It does not mean that you have severe PAH so आप bedridden ही रहो. You need to move about and have a good and active lifestyle. So these are some changes with the right therapy which will help in patients with pulmonary artery hypertension.
Thank you, Doctor. Dr. Milan, recently we've also kind of, at least hope we have covered the COVID kind of a challenge. Of course, it's still lurking around here and there. But in your observation, and I think I'll throw it open to all the doctors as well, have you found that there is now an increased occurrence of pulmonary hypertension among people?
Okay. So first of all, yes, we have seen many patients who develop pulmonary hypertension. But look, we have to clear one thing. Look, we can divide such patient in two groups. One group of active infection means that person who are currently infected with COVID, particularly who are severely ill, like pneumonia, ARDS patient, because there is destruction and severe inflammation in their lungs. It will lead to look clotting of blood and also destruction of that endothelial layer. Endothelial layer is a layer in small blood vessels. So when it destroyed, it will lead to clotting of blood, and ultimately it will lead to increased pulmonary artery, and it will cause thromboembolism and increased pulmonary pressure, pulmonary hypertension. So such patient we have seen very high mortality, right? And in second group, as post-COVID sequelae. Post-COVID sequelae means the persons who develop severe COVID, and after severe COVID, they luckily they got out from active disease. But because of that severe disease, they have some residual defect in any body part, like particularly in lung, like lung fibrosis, and there is persistent high pressure in pulmonary vessels. It's pulmonary hypertension. So and we have seen one trend that such patients, as time passed, they gradually they improved, and they come out of from all disease. And some unfortunate patient we have seen that died due to severe pulmonary hypertension and lung fibrosis, but that are very very less. And yes, what you are saying that patients having COVID in past now develop pulmonary hypertension. So such trend we didn't exactly, I didn't found that there is increase in increase in percentage of pulmonary hypertension patient in the society. No, not such cases is recorded. Yes, there is many patients who develop pulmonary hypertension, but because of that severe illness, severe COVID illness. But who develop mild illness or after what vaccination, some unfortunate patient develop stroke, myocardial infarction, even pulmonary thromboembolism. But that pulmonary hypertension we didn't see in many such patients.
Okay.
I think sir Gopal sir has also seen many patients. What do you say about this?
Yeah, absolutely right that Milan is telling that those who have a very bad COVID involving the lungs, they have more chance. But straight away, COVID related pulmonary hypertension without that thromboembolism is not we have seen commonly. Okay.
So perhaps, there's like a fear psychosis everywhere that now for all complications, let's blame COVID. I think that's how it's become. A general mindset has been reset that way. Fair enough, actually. Thank you, Dr. Milan, for coming out there and putting yourself out there on the line to claim and state that fact. Dr. Jail, I'm coming back to you now. And, in today's day and age, everybody is on the move, especially post-COVID. I think everyone's on the move with a vendetta. No one seems to want to stay at home anymore. But it is very serious when it comes to patients suffering from pulmonary hypertension. So be it work, be it leisure, be it wanting to explore all the corners of the world because they were stuck at home for 2 years. Can you help our listeners and followers understand what should be their modus operandi when it comes to traveling if they have pulmonary hypertension?
Yeah, so in this new age, traveling is it's the backbone of our economy. So if the patient is a pulmonary hypertensive patient, and so in that case, traveling is a somewhat a tricky issue, because first thing about the destination, like traveling at higher altitudes altogether should be avoided by such patients, because that might aggravate your disease, that might increase the severity, and might increase the pulmonary pressures. And traveling during the traveling, we have to be also making sure that the patient, if is not the hydration status of the patient should be thoroughly monitored, particularly if the patient is traveling. So avoid the dehydration and drink adequate fluids during the traveling. And you have to remain, if we are having a long haul flight, particularly during traveling, then you have to be somewhat active, in your during the flight. Also, you have to do some aerobic exercises also, such as you might have to walk after an hour or two. You have to keep your somewhat active. And during traveling, always consult your respected doctor before traveling. And always have a provision for supplemental oxygen if you are having a regular requirement for oxygen, or you have some past episodes of some exacerbation. So have some arrangement for the emergency availability of oxygen in the case if it needs. And another important, you have to take your medicines very regularly during your traveling. You should not be lax regarding your dosages of medicine and its timing. So you have to take it very regularly. Do not skip your any dosage of medicine. And always it's a good idea to consult your doctor before traveling, and it will definitely help.
Thank you, doctor. Especially the point about high altitude is something that they need to keep in mind for sure. Thank you, doctor. Dr. Vyom, let's now talk about, just something that out of interest we would like to know. Are there any new treatment modalities or technological advancements that you can tell us about, which could be rays of hope for patients?
Yeah.
We have already.
Yeah. So when we talk about the treatment, we should first be talking about the group of pulmonary hypertensions. Like already it has been mentioned that the left heart disease and lung diseases and thromboembolism are usually the common causes. So when we know that are the reasons, their treatment is definitely different. So the other group which usually when we talk about pulmonary hypertension is the idiopathic pulmonary hypertension, which is a group where we only have limited treatment options available. So first two groups has already been mentioned by Dr. Akash, is that phosphodiesterase inhibitors and endothelial receptor antagonists, which are easily available and readily used by most of the practitioners. So after that, the third group that comes in is the prostacyclin analogs, which till date were only available as IV continuous infusions. So patient has to have a pump which continuously keeps on giving the drug. But now we have oral prostacyclin inhibitor, which goes by the name of Selexipag. So which can be started as the third line of treatment in these patients, and then be up titrated. So this is now available in India also. And the fourth drug which has undergone phase 3 trial and have shown very promising results, it's sotatercept. So this drug is going to hit market in a year or so. So it's going to be fourth available treatment for such pulmonary arterial hypertension patients. So after this treatment availability, even if the patient doesn't improve, or as already mentioned that it is a progressive disease, so definitely we can slow the progression, but we cannot stop it. So at the time when the disease progresses fast and the patient is not able to improve with all the line of treatment, then we come to what is called as a palliative treatment. Palliative treatment is either we undergo atrial septostomy, which is possible, and it can increase some years of life in those patients. And last but not the least is the heart-lung transplant, which is becoming reality now. So these patients have an ultimate option where we don't have further treatment to be given, and there is no other treatment available. The heart-lung transplant is the answer to that situation.
Thank you, Doctor. Dr. Akash, can you, along with these treatment modalities, can you list out, are there any supportive therapies for pulmonary hypertension patients?
As everyone has discussed that pulmonary hypertension is actually progressive disease. So it needs to be slower its progression. So there are few things like if patient has lower oxygen saturation, less than 90, the patient will need the continuous oxygen therapy. Continuous or intermittent or CPAP therapy, that depends on patient to patient. Second thing, there is some studies like few groups of pulmonary hypertension, like idiopathic pulmonary hypertension, and because of clot like CTPH. So these two group, we had used the blood thinners are also has been used, like warfarin is used. So it can also help in for some extent. And these patients of pulmonary hypertension are actually very weak patients. So these are the immunocompromised patients, we can consider them. So vaccination is a very important part to slower the progression and to prevent the infection. So pneumococcal and Haemophilus influenza vaccine are compulsory for these patients. Other than that, there are few medications like in these patients, they have the volume overload situation. Like as Dr. Neil has told that they have the water, ample amount of water in that. So we can use diuretics. And there is a one drug digoxin we call, it can also be used, but how much it is helpful, it is a debatable question. So these are the supportive treatments which can use. Other than that, Dr. Vyom also has discussed atrial septostomy and heart lung transplant. Other than that, if patient has, if it is related to clot, CTPH, which is clot in pulmonary artery. So embolectomy is also one option. So these are the different modalities which we can use to slower the progression of disease.
Thank you, Dr. Akash. Dr. Gopal, I'm coming to you with a very basic, might sound. Yes, Dr. Nee.
Just one point I wanted to raise with what discussion we had just now, that Dr. Akash mentioned an oxygen saturation of less than 90%. Now, specifically because we are talking about pulmonary artery hypertension, with respect to the lungs, as well as with respect to a lot of cases even of other idiopathic causes of pulmonary artery hypertension, we normally usually have cutoffs of oxygen saturations as well as even the blood oxygen levels in the blood. But in cases of, at least in chronic lung cases, there can be a situation where the oxygen level long term of a patient is between 90 to 93. It is not exactly less than 90. But in such cases, still, despite having moderate or severe pulmonary artery hypertension, this disease itself becomes the indication for oxygen therapy besides the oxygen level. So here, the oxygen therapy is not only for maintaining a higher level of oxygen, but it helps with the long-term control of the pulmonary artery hypertension, as well as the morbidity related to that pulmonary artery hypertension for the lungs. So कोई पेशेंट को ऑक्सीजन सिर्फ इन केसेस ऑफ पल्मोनरी आर्टरी हाइपरटेंशन, ये एक ऐसी बीमारी है कि जिसमें कम ऑक्सीजन के लिए ही नहीं, पर इवन ये डिजीज के लिए भी ऑक्सीजन supportive treatment of oxygen therapy is going to help for the long-term course of such patients. Just that one point I wanted to add.
Yeah, that's an excellent point also, doctor. I think that makes that is very important information for everybody to know. Don't wait for it to go reach 90 and then start oxygen therapy. If they require oxygen therapy, regardless of their saturation, they should continue with their oxygen therapy. Am I right? Is that what you intended?
With guidance from a specialist and with what their physical tolerance and the exertional desaturation. That parameter also we use a lot these days, that after 6-minute walk test, 6 minute chalne ke baad oxygen kitna drop hota hai. So not only your resting oxygen, but the level after walking, how much is it? That can help in determining the need for oxygen earlier. If at all, it will help that way.
Super. Thank you, Doctor. Dr. Gopal, actually, my question to you, I'm not keeping it as simple as just, is it curable? But yes, definitely, I'm sure there are many people out there who would like to know, A, is PH curable? But my question is more, is it reversible? And, Dr. Milan's already told us that we can slow it down. But could you help us understand, are there levels of it, which can be cured or not?
First of all, that pulmonary hypertension is not a curable, it is a treatable. And as all that now for last more than 45 minutes, we are discussing about the treatments. So regarding that pulmonary hypertension, generally my cardiologist friends are also agree that is a class 1, 2 3, and 4. According to that, we plan out the treatment, whether he needs a single drugs or dual drugs. And as Dr. Neil has mentioned, we monitor the patients on that way. Okay, or suppose the patient is on class 3 and with drugs, he may come out to class 2. Just little bit improvement in the quality of life and the monitorings. It is not totally reversible. Patient symptomatic score and sometimes what the marker is a anti-pro-BNP blood marker certain, and the 6-minute walk test, how much distance he walked with the drugs. Suppose without drugs he walks certain distance, and after starting the drugs, might be the distance walking can increase. So with the drugs, and you have to categorize which class of the patient, and according to that, available drugs, that is the definitive treatment of the pulmonary hypertension with supportive treatment and some preventive treatment. With that, you have to monitor the patients, and we have to slow down the progressions of the disease, or sometimes some extent we can restrict the progression of the disease, and we can avoid the precipitating factor which can worsen, like Dr. Neil has mentioned. We should not wait for a hypoxemia, because if hypoxemia itself leads to constriction of the vessels. So we try to prevent that, and we have to give the oxygens. By that way, we can restrict the progression, or we can reduce the progression of the conditions. That's the things we have to mention.
Well taken, Dr. Gopal. But I have one more question to you. At what stage must a patient or his or her bystander decide that home therapy or home remedies are not good enough, or home care is not good enough, and they should take the patient to a hospital?
Yeah, if the patient is coming to class 3, class 4, suppose a patient is not feeling and not maintaining and persistently having the complaints, his parameters, pressures are increasing, then that time we need to be hospitalization, and we can, a patient may need beyond the oxygen therapy, like supportive, non-invasive BiPAP like therapy. So that therapy, and sometimes patient needs dual drugs we started, which has to be monitors now, and certain drugs that mentioned. So for that monitoring, that the blood thinner medication, in that way we have to hospitalize the patient for supportive care and some sort of the definitive care.
I'm going to stick with you again and ask you, I always believe that while the patient really struggles and suffers, bystanders struggle too. Do you have any word of advice to bystanders of pulmonary hypertension patients, whether it's at home or in hospitals?
That is the way earlier I mentioned, that's the rehabilitation. In that we explain the patients and patient relative regarding the condition of the patient and what is the prognosis of the patients. And suppose that nowadays, day by day, when I started my practice, there were only 2 drugs and supportive drugs. Nowadays, good amount of drugs, certain options like heart lung transplant. So if patient is a young patients, relatives are willing, then we can go for certain conditions. And as Dr. Akash mentioned, thromboendarterectomy. Suppose the pulmonary hypertension, we believe that is because of the chronic thromboembolism. In that case we can explain the bystander what are the available modality of the treatments. And suppose everything we utilize, still the patient is not improving, then we can discuss the end of life care, as the critical care specialists we used to discuss with the patients relatives.
Thank you, Doctor. Dr. Neil, we've been hearing the terminology of sleep apnea. Could you help us understand the connect between pulmonary hypertension and sleep apnea a bit better? And perhaps, maybe define sleep apnea for us in a more layman's terms.
So sleep apnea, what basically has come into the limelight since the last 1 year, because like in India, we follow celebrities. So any one celebrity has any major disease, everybody will be aware. So it is basically when you sleep, at that time, your airways, they tend to constrict because of the laxity in the muscles near your main central airway pipe. So during sleeping time, when this happens recurrently, especially in patients who have a short neck and who are obese or who have a facial morphology or other genetic risk factors which make them prone. So during sleeping, they have recurrent episodes when the airway is constricted. So that causes recurrent arousals during sleep time. So जो नॉर्मल हिस्ट्री है, जो नॉर्मल कंप्लेन पेशेंट करेगा या उनका पार्टनर करेगा, इज दैट इनको स्नोरिंग ज्यादा होता है और रात को बार बार जाग के उनको चोकिंग के एपिसोड्स आते हैं, जिसके कारण उनका पूरा गला भी सूख जाता है। तो बार बार रात को गला भी सूख जाता है। एंड सुबह जब वो पेशेंट उठता है तभी दे फील मोर स्लीपी एंड मोर ड्राउजी, दैट दे डोंट फील दैट आई हैव हैड अ गुड स्लीप। एंड विथ दैट देयर इज सिम्टम्स ऑफ डे टाइम स्लीपीनेस, कि दिन में ज्यादा उनको नींद आती रहती है रूटीन काम करने पे, व्हीकल में ड्राइव करते वक्त देयर हैव बीन एक्सीडेंट्स बिकॉज ऑफ स्लीप एपनिया। तो वो चीज है कि स्लीपीनेस दिन में ज्यादा होना। Now the connect between pulmonary artery hypertension and sleep apnea is important because ये रात रात में जब जब ये कंस्ट्रिक्ट एयरवेज होता है, जो चोकिंग होता है, तब तब आपका ऑक्सीजन लेवल कम होता है। जो स्लीप स्टडी में है, जब हम मेजर करते हैं कि कितनी बार एक घंटे में आपको एपनिया हुआ, कितनी बार एपनिया यानी सांस रुक जाना, हाइपोपनिया यानी सांस कम आना, तो ये एक घंटे में कितनी बार हुआ, और एक जितनी बार हुआ उतने टाइम आपका ऑक्सीजन लेवल कितना नीचे गया। वो जो ऑक्सीजन कम होता है वो आपके हार्ट, लिवर, किडनी, लंग्स, ये सब जगह पे ऑक्सीजन कम करने वाले। तो द पल्मोनरी आर्टरी ऑल्सो, वो पल्मोनरी आर्टरी जो लंग्स को उसकी भी ऑक्सीजन लेवल कम होती है, उसके कारण उसका वेजो कंस्ट्रिक्शन बढ़ता है। तो ये जो एपिसोडिक जो चोकिंग एपिसोड्स हो रहे हैं या एपिसोडिक जो स्लीप एपनिया के कारण ऑक्सीजन कम हो रहा है, ये लंबे समय से इससे भी पल्मोनरी आर्टरी हाइपरटेंशन होगा। और व्हेन देयर इज अ कॉम्बिनेशन, कि जब आपको स्लीप एपनिया है और पल्मोनरी आर्टरी हाइपरटेंशन दोनों है, कॉमनली ये टाइप 3 या तीसरे प्रकार के पल्मोनरी आर्टरी हाइपरटेंशन में होता है। तो ऐसे केसेस में जो भी प्राइमरी जो लंग का भी रोग है, उसकी भी ओवरऑल प्रोग्नोसिस थोड़ी ज्यादा, दोनों का ध्यान रखना पड़ेगा। कि जैसे आप स्लीप एपनिया का आपने बराबर से ट्रीटमेंट लेना पड़ेगा, सीपैप का मशीन, जैसा डॉक्टर गोपाल ने डिस्कस किया था कि सीपैप का मशीन है जो हम यूज कर सकते हैं। साथ ही साथ जो जिसमें वो यूज करने के बावजूद उनका पल्मोनरी आर्टरी प्रेशर फिर भी बहुत ज्यादा रहता है, तो ऐसे केसेस में कुछ और लंग्स रिलेटेड कारण है। इज देयर एनी एयरवे डिजीज, डज द पेशेंट्स लंग वॉल्यूम्स नीड एनी इनहेलर थेरेपी, कुछ रिहैब की जरूरत है। तो वो सारी चीजें स्लीप एपनिया के दर्दी को ज्यादा ध्यान रखने की जरूरत है। और यही पेशेंट्स इवन जिनको, जैसे हमने अभी बीच में बात किया था कि ऑक्सीजन थेरेपी, सो लॉट ऑफ पेशेंट्स जिनको क्रोनिक स्मोकर्स होते हैं, लंबे समय से लंग्स का प्रॉब्लम है, साथ में स्लीप एपनिया भी है, तो वैसे पेशेंट्स में ये सारी चीजें जो लंबे समय के लिए सीपैप या बाईपैप मशीन का उपयोग और ऑक्सीजन थेरेपी, ये सारी उनका डिजीज का प्रोग्रेशन अटकाएगी। like he said, prevention is better than cure. In pulmonary artery hypertension that is definitely true, but we have to also prevent the progress. So हमारा पूरा गोल ये पूरे डिस्कशन का ज्यादा वो रहता है कि कैसे हम इसका जो भी हार्ट के रिलेटेड, लंग के रिलेटेड, क्लॉटिंग के रिलेटेड जो भी कारण से हम वो पल्मोनरी आर्टरी हाइपरटेंशन का प्रोग्रेस कैसे अटकाएं, तो उसमें हमें इससे थोड़ा मदद मिल सकता है।
Thank you, Doctor. I think that made it very clear indeed. My final question is to Dr. Milan. I think Dr. Neil already touched on it a little earlier, but perhaps you can help us understand how vaccinations could be a good preventive or could be a good way to, protect us or slow it down or whatever. Could you give us the connect?
Yes. Look, actually, vaccination has not directly role as a treatment part in pulmonary hypertension, but it's very, very important aspect. Actually, pulmonary hypertension treatment has two phases. One is the medicines, so we can give drug tablets or injection like this. And another phase is like diet modification, exercise, vaccination, etc., etc. Right? So, look what happened. Patients with pulmonary hypertension are very fragile, and their lives, basically lives on edge. They look so well, but they are not actually. Even some form of stress will land there with severe respiratory failure and land them in ICU. Right? Any form of stress like infection, pneumonia, whether viral or bacterial, can cause severe respiratory failure. So it will ultimately increase mortality and morbidity in such patients, right? With very high economical burden to patient's family. So it's better to avoid such infection as far as possible. How we can prevent infection? There are again many two part mainly. One is vaccination. we have no vaccine for all virus or bacteria, but हमारे पास जितने vaccine है we should give, right? Particularly flu vaccine should be given every yearly, and pneumococcal vaccine should be given every 5 yearly in such patients, right? And yes, and other part, how we can prevent infection other than vaccination? Yes, definitely that we will learn by COVID, right? Social distancing. So such patients, it is always better to remain social distanced. Means not to first degree relative, but they should not go like avoid gathering, avoid social gathering, right? Many major functions like marriage or engagement or any parties, they should avoid as far as possible, right? So it's very important that we can prevent preventable infection by vaccination and by social distancing and mask.
Absolutely. I think the entire tone and tenor of today's discussion has been extremely positive, because at all points in time, all of you have shared your wisdom and your experience with us and helped us to understand that here is something that can't be cured, but it can definitely be treated. And the rate and pace of deterioration can be slowed down to an extent where patients can still enjoy and hope to enjoy good quality of life. Well, that's a very positive note for us to end on. And I'd like to thank all the doctors who are here on behalf of MSN Laboratories in association with Times of India. Please let me thank Dr. Jael Shah, Dr. Vyom Mori, Dr. Akash Ramchandani, Dr. Gopal Raval, Dr. Neil Thakur, and Dr. Milan R. Bhanderi. Thank you so much for being here today, for sharing your time and expertise with us, and for sharing so much knowledge. Indeed, World Pulmonary Hypertension Day is marked by added awareness thanks to you. Thank you and have a good evening.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.